Hello, this is Mrs. Page, and this lecture will cover cardiac dysrhythmias. Cardiac dysrhythmias are abnormal rhythms of the heart's electrical system that can affect its ability to effectively pump oxygenated blood throughout the body. Some dysrhythmias are life-threatening, whereas some are not. When talking about cardiac dysrhythmias, there are certain definitions that we need to know. Automaticity is the ability of the cardiac cells to generate an electrical impulse spontaneously and repetitively. Normally, only the SA node can generate an electrical impulse, but if the patient is having an MI, an electrolyte imbalance, hypoxia, or drug toxicity, any cardiac cell can produce electrical impulses independently, and this can cause dysrhythmias. Excitability is the ability of a non-pacemaker heart cell to respond to an electrical impulse that begins in pacemaker cells. Depolarization or contraction occurs when the normally negatively charged cells within the heart muscle develop a positive charge. Repolarization is the relaxing of electrical forces, or a period where things return to normal, or when the heart is resting. Conductivity is the ability to send an electrical stimulus from cell membrane to cell membrane, and contractility is the ability of the atrial and ventricular muscle cells to shorten their fiber length in response to electrical stimulation, which causes sufficient pressure to push blood forward through the heart. In other words, contractility is the mechanical pumping activity of the heart. Electrocardiogram, or ECG or EKG, is a graphic representation of cardiac electrical activity. Electrodes are placed on specific sites of the body and attached to the EKG machine. Electrical current is transmitted through the electrodes, through the wires, to the machine, and a graph is formed. A lead provides one view of the heart's electrical activity. A 12-lead EKG shows 12 views of the heart's electrical activity. An 18-lead or right-sided EKG adds 6 more leads to the right side of the body and then shows 18 views of the heart's electrical activity. Continuous ECG or EKG monitoring includes 5 leads. These can be connected to the wall or via battery-operated transmitter, which is known as telemetry. When taking an EKG, here are some tips and tricks to make sure that the EKG comes out looking good. Proper placement of EKG leads is important. On this screen on the left-hand side, there's a diagram of exactly where the electrode should go in reference to the patient's body. Remind the patient to breathe normally and be as still as possible. The patient should be in a semi-reclined position or as close to supine as they can be comfortably. Hair should be clipped and the skin should be clean. After the EKG is done, the 12 electrodes should be removed. Do not place electrodes over scar tissue, a port, or any type of open skin. On the right-hand side of the screen is a diagram of the 5-lead system. You can see that each electrode is color-coded, and a way to remember this is white on right, smoke over fire, green to the grass, and chocolate close to the heart. The white electrode will go on the right side. Smoke, which is usually black, goes over fire, which is usually red, so this black electrode will go on top of the red electrode on the left side. Green to the grass, the right lower portion, and chocolate close to the heart will go right in the middle near the sternum. When looking at EKGs, you need to be able to read the EKG paper. A small square is 0.04 seconds. A large square is 0.20 seconds. There are also tick marks that you will see on the top of an EKG. Between one black tick mark and the next black tick mark is 3 seconds. there's also 15 large squares, and between 3 black tick marks, 1, 2, 3, there are 30 large squares, or 6 seconds. Normal conduction of the heart starts with an impulse to stimulate the cardiac muscle to contract. It follows the pattern of SA node to AV node to bundle of His to Purkinje fibers. The SA node is the heart's primary pacemaker. It generates impulses at a rate of 60 to 100 beats per minute. The impulses from the sinus node move through the atrial muscle and lead to atrial depolarization or contraction, which is reflected as the P wave on an EKG tracing. The electrical impulse then moves from the SA node to the AV node. If the SA node is not functioning properly, then the AV node can take over as pacemaker. The AV node generates impulses at a rate of 40 to 60 beats per minute. T cells cause impulses to slow down or be delayed before proceeding to the ventricles. This delay from the SA node to the AV node is reflected in the PR segment on the EKG. This delay allows the atria to contract and the ventricles to fill. After the AV node, the electrical impulse is then sent to the bundle of His, which splits into the right and left bundle branches. After the right and left bundle branches, it splits further into the Purkinje fibers, which are located on the endocardial surface of the ventricles, and they partially penetrate into the myocardium. The Purkinje fibers are responsible for ventricular depolarization, which is represented as the QRS complex on the EKG. If the AV node fails, the Purkinje fibers will take over as the pacemaker of the heart and will only send impulses at 15 to 20 beats per minute, which is also known as a complete heart block. The cardiac cycle is the period of time from the beginning of one heartbeat to the beginning of the next. Contraction and relaxation of the atria and the ventricles occur during the cardiac cycle. To be normal on the EKG tracing, there must be a P wave, a QRS complex, and a T wave. Once a cardiac cycle is identified, intervals of each component are measured. The P wave represents atrial depolarization or contraction. This indicates SA node function. P waves should be round and upright, and one P wave should occur per cardiac cycle. One P wave should also occur prior to a QRS complex. The PR interval represents the time it takes for electrical impulses to move from the SA node to the AV node. The PR interval is measured from the start of the P wave to the start of the QRS complex. Normal length of the PR interval is 0.12 to 0.20 seconds. The QRS complex represents ventricular depolarization or contraction. Not all QRS complexes may have a Q, but they are still normal. These are a few of the variations of the QRS complex that you might see. The QRS complex is measured from the beginning of the Q to the end of the S, and normally it is less than 0.12 seconds. The T wave represents ventricular repolarization or relaxation. The T wave should be upright and round. If the T wave is inverted, it can represent ischemia, and if you have tall peaked T waves, it can represent hyperkalemia. The ST segment starts at the end of the QRS and ends at the T wave. The ST segment is usually flat and comes back to the isoelectric line. If the ST segment is depressed, it can indicate ischemia or digoxin toxicity. If the ST segment is elevated, it can indicate injury or infarct. There's also the QT interval, which measures ventricular depolarization and repolarization. The QT interval usually lasts between 0.36 seconds to 0.44 seconds. When interpreting cardiac rhythms, there are 8 steps that we can follow. 1 is determine the rhythm, 2 is determine the heart rate, 3 is analyze the P waves, 4 is measure the PR interval, 5 is measure the QRS complex, 6 is examine the ST segment, 7 is analyze the T waves, and 8 is measure the QT interval. Step 1 is to determine the rhythm. We can assess for atrial and ventricular regularity using 2 methods, the paper-pencil method, which is what we will use, or the caliper method. For atrial rhythms, measure the P to P intervals. So you'll place one caliper point on the first P wave and the next caliper point on the next P wave. You'll move the caliper from P wave to P wave along the entire strip to determine the regularity. The same process will be done with the paper-pencil method, except we will use a piece of paper and mark the first P, and then mark the next P. After the space between the P waves has been measured, we will then move the sheet down the strip to determine if the P waves are evenly spaced. For ventricular rhythms, the same method is used as atrial rhythms, except you're using the most prominent part of the R wave instead of the P wave. Heart rhythms can be regularly irregular, occasionally irregular, or irregularly irregular. Step 2 is to determine the rate. EKG paper is marked in increments of 3 seconds with a vertical line or the black tick mark at the top. If there are no tick marks, you can simply count out 30 large squares and that will give you 6 seconds. Using a 6-second strip, you can count the number of P waves, or the atrial rate, or R waves, the ventricular rate, and multiply by 10 to give you beats per minute. In this example, there are 8 R waves. Multiplying that by 10 gives you 80 beats per minute. Step 3 is analyzing the P waves. You should check that the P wave shape is consistent throughout the strip. Ask these questions. Are the P waves present? Is there one P wave for each QRS complex? Are the P waves smooth, round, and upright in appearance, or are they inverted? And do all P waves look similar? In this example, all the P waves are round, upright, similar in shape, and before each QRS complex, which is a normal finding. Step 4 is measuring the PR interval. Remember, the PR interval is from the beginning of the P wave to the start of the QRS complex. You'll want to count the small squares between the start of the P wave and the start of the QRS complex, and then multiply by 0.04 seconds. Normal PR interval is 0.12 to 0.20 seconds and constant throughout the entire strip. In this example, the PR interval is 4 small squares. Multiplying that by 0.4 seconds gives you a PR interval of 0.16 seconds, which is within normal limits. Step 5 is measuring the QRS complex. Count the number of small squares between the beginning of the QRS and the end of the QRS complex, and multiply by 0.04. Normal duration of a QRS complex is between 0.06 and 0.12. When you're assessing the QRS complex, also ask these questions. Is there a QRS complex after every P wave? And are the QRS complexes similar in appearance across the strip? In this example, the QRS complex is 2.5 small squares long. Multiplying that by 0.4 seconds gives you a QRS complex of 0.10 seconds, which is within normal limits. Step 6 is examining the ST segment. Normal ST segment begins at the isoelectric line. ST elevation or depression is significant if displacement is 1 millimeter, or one small box above or below the line and seen in 2 leads. ST elevation can indicate problems like MI, pericarditis, and hyperkalemia. ST depression is associated with hypokalemia, MI, or ventricular hypertrophy. On the far left of the screen, you can see an example of a normal ST segment. On the right-hand side of this diagram, you can see an example of ST elevation, where it doesn't come back down to that isoelectric line. In the bottom right-hand side, you can see different types of ST segment depression, such as upsloping, downsloping, and horizontal depression. Step 7 is analyzing the T waves. Note the shape and height of each T wave. Check for peaked T waves indicating hyperkalemia or inverted T waves indicating myocardial ischemia. Step 8 is measuring the QT interval. Count the number of small squares between the beginning of the QRS complex to the end of the T wave. And multiply by 0.04. Normal duration of the QT interval is 0.36 to 0.44 seconds. This QT interval example is 9 small squares long. Multiply that by 0.4 gives you 0.3 seconds, which is within normal limits. As a review, P waves should be round and upright and before each QRS complex. PR interval range is 0.12 seconds to 0.20 seconds. The QRS complex should look similar throughout the strip, and the duration should be from 0.06 seconds to 0.12 seconds. The ST segment should come back to the isoelectric line. T waves should be upright, not peaked or inverted, and the QT interval will range from 0.36 seconds to 0.44 seconds, but can vary with heart rate. You might see shorter QT waves with tachycardia and longer QT waves with bradycardia, because remember, the QT interval is the time it takes for the ventricles to contract and relax. Some medications can also extend QT intervals. I want you to pause the slideshow and try to figure out what this rhythm is using the 8 steps that we've previously discussed. Step 1 is determining the rhythm using our paper-pencil method. Mark out the P to P interval and then move it to each P to P interval and see if it is regular or irregular. We will want to check the entire strip, but for demonstration purposes, we can go ahead and determine that this is a regular rhythm because the P to P intervals are evenly spaced. Step 2 is to analyze the rate. Make sure you are using a 6-second strip. This one is marked with the black tick marks, but if it wasn't marked, then you could count out 30 large squares. So count how many QRS complexes there are, and multiply by 10, which would give you 80 beats per minute. Step 3 is to analyze the P waves. They should be consistent, upright, and before each QRS complex, which they are. Step 4 is measuring the PR interval. We'll need to zoom in on this one. Starting at the beginning of the P to the beginning of the QRS complex, there are 3 small boxes. Multiply 3 by 0.4, and that gives you 0.12 seconds. This is a normal range for a PR interval. Step 5 is measuring the QRS complex. They all appear upright and consistent throughout the strip. We'll zoom in and count the small squares from the beginning of the Q to the end of the S, which is 3 small squares. Multiply 3 by 0.4 seconds, gives you 0.12 seconds, which is within normal range for a QRS complex. Step 6 is assessing the ST segment. I like to draw a line or use my paper to look at the isoelectric line all the way across. And we can see that our ST segments are not depressed or elevated, so they are isoelectric. Step 7 is analyzing the T waves, specifically looking to see if they are peaked or inverted. These T waves are upright and they are not peaked or inverted. Step 8 is measuring the QT interval, which is the beginning of the QRS complex to the end of the T wave. There are 10.5 small squares. Multiplying that by 0.4 seconds gives you a QT interval of 0.42 seconds, which is within normal range. After going through all 8 steps, we can then interpret the rhythm, which is normal sinus rhythm. Now that we know what a normal rhythm looks like, we can move on to the different types of dysrhythmias that we will see. I'm going to post dysrhythmias in a separate PowerPoint recorded lecture, so make sure that you go and watch part 2 of this lecture.